Okay, so I think we are now good to proceed ahead in some sense to the again it is going to be still the introduction, but then modality specific kind of a big picture view of each of the modality. It's historically where when was it started to being used for medical imaging and how it has progressed, and can we identify a few big names who have contributed a lot to development of each of the modality. So, right. So, having looked at terminologies, right, I think going forward, whenever there is usage of some of the terminologies that we have covered so far, I will try to highlight, reiterate. That way you will be able to connect and reconnect with it's just a question of getting familiarized. I think there is nothing, it's all very, I mean the thing that I like about this subject is it's very intuitive, right? At least the most topic is intuitive and you can visualize it, and so it kind of it will start to make sense and you will be able to feel for what it is, but then also you have to be cautious that even though it may give a feel good factor, it still requires the old style. You have to spend hours on the details to really know the nitty-gritties to appreciate it better. Okay, so let's take the positives and say, look, I saw these images, now I know the images. There are several different modalities of interest. Here are few that were shown, some for anatomical image or structural image and some for functional image. So, that is, you can start to see the actions that are taking place, like in PET for example, right. So, let us go forward, let us see what are the modalities of interest for this course, this module, and kind of dwell some minutes that it deserves to at least appreciate how far each modality has come through and what is their role in the current state of things, and if possible you can orient yourself to see where can I push the state of the art, right. So, the different imaging modalities of interest are going to be, we saw this X-ray based, projection radiography. So, now I think you should be able to quickly recognize what we mean by projection, right. So, X-ray, okay, that is a modality we talked about, which we will again go one by one more time, but just to kind of make you aware that why we covered certain terminologies before we came here is, if we are going to use projection radiography without telling you what projection means, right, it won't you will not get the feel for. Now, looking at the name projection radiography, immediately you should start to recall, you should start to appreciate what modality, what images you have taken so far, what you have seen so far that can come under projection radiography, right. We have done that, we will do it again and again because this is something that you would have experienced personally as well. Chest X-ray, right, we gave an example of chest X-ray, volume collapsing to a projection. So, projection radiography, and then computed tomography. This is very important because as it says, it is just computed tomography. So, it is essentially mathematical, right, it does not tell which signal it is, right. So, people call it CT scan, I go for CAT scan, but most of the time they are implying that it is, if they say just CT or if they say CT scan, they kind of implicitly mean, because the popularity is X-ray based computed tomography. The signal of interest is X-ray is the probing signal. And notice here then is nuclear medicine. Why did we cover the terminology here? What is this T? This T is tomography. So, tomography is a mathematical concept, right. So, it can take the signal, the physical meaning of the signals or the variables that are operated in the mathematics can have meaning based on the signal. So, it can be X-ray based, it can be nuclear medicine. We will expand all this going forward. We already did this. This is positron emission tomography, right. So, you can see why we covered projection. Now, you know why we covered tomography, what we mean by tomography, recall, right. Oh, we take projections, we take views from different views, we take projections from different views and then reconstruct the through slice, right, through direction or the depth direction. Okay. So, then you are talking about ultrasound imaging. So, we will cover about ultrasound imaging. Finally, in fact, you know, it's always the case, right, you keep the best for the last. So, MRI, that's a very interesting imaging modality, very versatile. I think it might be too complicated if we just start with that. So, we will go systematically in this order. That way there is some connection, both the historical development, at the same time how the modality evolved and the complexity and the mathematical principles that we may use, right, we can start to sort of add on. So, we get to the most complex and versatile modality towards the end. Okay, clear. So, what we will do now is take one modality at a time in the same order that is listed here and kind of have a big picture view. What do I mean by big picture view? We have already defined objective of medical imaging, right. We already defined or discussed the requirements, or at least the general requirements for any imaging modality. So, now and then we also touched base and said each modality is different, each one brings different value. So, now we will try to take each modality listed here and relate it to whatever we have covered so far with respect to its general, how does it satisfy the overall objective, what is it, how does it satisfy the general requirement, you know, and so on and so forth. Clear. So, let us get to the first modality. I mean, like I said, this is coming from the textbook reference, but I keep repeating, this is something that is very intuitive. You would have walked out at this point of time, most of you at least would have gone for taking a chest X-ray for yourself, or you have accompanied someone, right. So, this is what they do. They have a room and there will be a safety signal, right, stop, red, do not enter, and then because there is a radiation. So, all the information that has to be available to warn you to not just enter, to minimize the risk of radiation, right, will be there. So, you enter the room and you will notice some setup like this, and what typically happens is the operator is going to say, oh, go stand there, right. He will ask you to stand there, and then he will actually politely walk out, right. So, he will not stay in this region, and he will go and he will give you some intimation and then say, oh, it is done. So, you will not really feel anything, you will just go there, you will stand still, and he will say, okay sir, done, you can come, right. So, you would have experienced that. What is happening? You go stand there, this is generating an X-ray, it is sending through and you are standing here. So, the X-rays are going through your body, coming out through the other side, right, and it is getting collected here. So, in some sense your whole 3D is collapsed into the plane of this guy, this detector, and then of course, they do the development and you get a typical, nowadays it is digital radiography, but I am sure you would have seen several places a film, right, they keep it and the doctors keep it under the light illumination and see like how you see here. So, this is something that you are familiar. What do you, what like we just reiterate one more time, the challenge here is it is projection, and therefore, my 3D is collapsed to plane of paper. So, I cannot tell from this whether it is the front of my rib cage or back of my rib cage, or is there anything, if there is anything that is there, right, obstructing, for example, or some nodule is there in the lungs. I do not know whether it is situated at the mid level or towards the back or towards the front. All I will know is it is there in the lungs at this location. I will not know what depth going from my front to back where that lump will be sitting, right. So that is the challenge. Nevertheless, this is one of I am sure you would have encountered, and therefore you can say that you wouldn't have felt a pinch. So it's, there is no the person who's going to get projection radiography, there is not much inconvenience to them, right. So that is a big plus. And also, why is it so popular? I mean, chest X-ray is one thing. I'm sure you would have gone for regular fracture, right. You fall down, they would have taken, if you fall down and you suspect you broke your arm, they'll just take an X-ray of your arm or your leg, right. So it's very common. I'm sure you would have seen this umpteen number of times. It's one of the oldest medical imaging modality, at least the way we defined medical imaging, right. So it was the X-rays were discovered in the year 1895 by Roentgen. I'm sure you would have heard of this name, and this NP represents Nobel Prize. So he received a Nobel Prize for this discovery in 1905. So you can see it's already more than 115 years old, right. Since the work was well recognized, and I mean, there's an interesting story. I think from what I gather, there is enough concurrence, right. People agree that the story goes like Roentgen was working on what is called as a Crookes tube, right. So it was a precursor to all the other tubes, that the X-ray tubes and other things. So he was working on Crookes tube, and he had gone for a vacation, and he came back, and it was a surprise there, right. So he was working, so he had actually concealed the photographic film, and he had gone for vacation, and he came back and he saw the photographic film was exposed, and he was not sure what happened, because he took all the precautions so that it is not exposed to light, but then he still he just saw that it was still exposed. So he said, okay, there is something beyond what we know, there is some other race that was there, and therefore, if you don't know much, you treat that variable as X, right. So he started calling that as a X-ray. So it was a accidental discovery in that sense. It was, I mean, it won't happen to you or me probably, but these are people who are not as average as us. They are intellectual. So somehow it occurred to him that this is not some random error, right. There should be some science behind it. So essentially he spent and dug out, and he called it X-ray, and did series of studies, and then he went on to take the first. Immediately it stuck to him, if that is the case, why don't we do it on humans, and we could see the inside, right. So that's how its application to medical imaging started. Okay. So X-rays, we saw the electromagnetic spectrum in the previous slides. So this is X-rays, it's electromagnetic radiation, we call this, right. It travels, the form of radiation is in the form of packets of energy, which they call as photons, right. So you send a packet of energy. So X-ray, when they are sending, what they mean is they are sending energy packets. The energy is in the X-ray range, right. So with this energy, so in the electromagnetic spectrum that we saw earlier, you saw that there was frequency axis, there was wavelength, there was energy, right. So you can list this particular, you can locate that in that axis. So this is ionizing. Okay, what it means to be ionized, we will go. In fact, that's what we will start with when we start the modality. And imaging principle, right. What is the imaging principle? So I shoot a photon, right. I shoot X-ray photon, that is photons having energy in the X-ray range. So it is going through the body. So when it is going through the body, it is going to interact with the medium, right. So our medium is going to try to stop the photons, it is going to take the energy away. So that means whatever is coming out is going to be less energy. So you send number of photons, less number of photons will come. How less the number depends on which path it is going through. So if I have a medium that is going to take more photons, right, absorb more photons, then I will get less in the background. So essentially X-rays penetrate tissue and create a shadogram. So with light, I do this in a typical classroom setting, so you could perhaps do it. So when we have a projector, I keep my hand, right, and you will see a shadow. So you can do this, you take a light and you show your hands, you will see a shadow. This is for visible light. Similar thing, when you have photons that is going, you get a shadow of how much, shadow based on how much is lost when it is passing through. So in visible light, if I obstruct the light, everything is lost. This is taking up, everything is getting bounced back. I don't see anything below. So the shadow will come behind the object. In same concept, right? But now it is depending on differences in density. So the density of the material and its properties, how it interacts with photons having X-ray energy, determines what pattern, right? What pattern of loss you are going to see. So that is what is the basic principle. So we'll dwell on this, we'll come to it, right? And then imaging volume. So other characteristics. What do we mean by imaging volume? Here what is attempted is, you can do the whole body. What we saw right now is chest X-ray, but there is no reason only for that. You can do the whole body, or you can do chest, or you can do hand. So this is the upper limit. So whole body can be scanned. So that is a advantage, right? I can quickly have whole body scanned without you knowing anything, without you feeling anything, right? Resolution is also very high. What do we mean by very high? This is the context, sub-millimeter. So imagine, so for example, if I take my height, okay, it's I could have tens of centimeters, right? So in case probably 175-76 centimeters. So centimeters, you can get a feel for what it is. So now I can see from my head to foot, I can see in terms of sub-millimeter. Alright, so you can start to appreciate. So if I am 177 centimeters, 1 millimeter is going to, is already small enough. So we could actually see details of sub-millimeter of how the densities are changing. Okay, so so you will start to appreciate this. Now you just I want you to have a feel for the numbers, right? Some range, at least orders of magnitude. Popular applications, mammography, right? Mammography is essentially used for breast cancer screening, right? It's a part of first screening protocol. So mammography, lung disease, right? Chest X-ray, right? If you do that, they do it. Orthopedics, basically fractures, right? So a very common everyday application that you would have encountered. Okay, so let's before moving to the next modality, just want to throw this, and several of you probably would have, it's a trivia kind of question, you would have you would have heard about this in quiz contest or something, but nevertheless it's fun. Just what is this? Oh, this is, by the way, what is considered to be the first medical image. So we just talked about Roentgen, who accidentally discovered X-ray and he immediately was smart enough to recognize its application in medical. So what did he do? He asked his wife, right? So she showed her hand, and this is their wedding ring, and so this happens to be the first medical image, right? First X-ray of human body, hand. Okay, good. So next, you probably read it already, computed tomography or CT scan or CAT scan, right? You notice X-ray, right, I said was discovered in 1895. When was CT? In fact, when they say year of discovered here, 1972, this is essentially based, so this work, based on this work where the concept of X-ray projection and the mathematics of reconstruction, computed tomography, was put to use, and for which Hounsfield received a Nobel Prize in 1979. Okay, so again the modality or the form of radiation is X-ray, which was there from before. But what was the challenge when Roentgen did it? It was only a projection radiography, right? You couldn't see the slice through what happens, what is there in the front, what is there in the back. You don't know. Everything is projected. You know, it took cool 75-80 years, you know, to take that physics, right, how it interacts, how much is attenuated, what is the medium property, all this nice theory, all those things. But it took cool 70-75 years before they were able to put all the pieces together and say, okay, here is a practical way I could get the slice image of the through slice or the tomograph, right. Otherwise nothing else is going to change, because it is still you are going to use, you are going to send X-ray, right, the photons, X-ray photons, right, and receive it. But in tomography, recall what did we say? Oh, you are going to take projections from different views and then put reconstruction algorithm, right. So that's what, so it's X-ray projection we saw. So if you can take the projection from, at least conceptually, we'll see the practical difficulties, but conceptually you take different views, so you get projections that are going to look different from different views. We did this, right, we took my cell phone and we said if you look at it from different direction, you are going to see different projections, the length was changing. So similarly this is going to happen. And how do you, and then you put them, reconstruct, you get X-ray computed tomography. So principle, the X-ray interaction is same, like attenuation with the material property is same as your X-ray projection radiography, but here the extra step is tomography part. So same advantage, you could do a whole body. So this is kind of 3D now, right? When X-ray projection of whole body is, you are going to get one direction of me. You can either collapse me from the front back, or you can collapse me from sagittal, right, coronal, sagittal or axial, right, it doesn't matter. Whereas here you are going to get 3D, right, you are going to get slice, so you can actually see every little detail where it is situated in X, Y and Z. Okay. Resolution, yeah, you have to go, there is always a compromise, you will see that is the whole idea. There is always a compromise. When you gain something, there is surely something that you are going to lose. If that is not the case, then there is probably something wrong, unless it is a paradigm shift, it is completely new. But anytime you are working with existing well accounted, well studied modality, the challenge is always, it's going to be, there's no one way street, right. So here what it is, resolution is still good, but not sub-millimeter, it is millimeter, right. I cannot get too greedy, right. I am now going to get X comma Y comma Z of my material property, how it attenuates X-ray, and if I can get that at millimeter resolution, right, for every millimeter comma millimeter, that's probably good. Of course, if it is sub-millimeter, you would still like, but then it is going to take, you're going to trade off somewhere. So we'll look at it. Again, application, you see soft, so the moment you said, oh, X-ray based imaging projection radiography was used. So if wherever there is a projection radiography can solve the problem, right, you don't really need a CT. I mean, if I can tell there is a bone fracture here, a quick and safe X-ray projection radiography, that's good enough, right. Where CT contributes is it provides good soft tissue imaging. So if I want to not just look at whether there is a bone fracture or a skull fracture, but I actually want to see the different soft tissues, I want to differentiate one soft tissue from the other soft tissue, then this becomes very important modality. Okay. So brain we actually saw some example, cardiovascular, CT angiography, right, you would have heard about that. And then GI is your gastrointestinal, so you can do a lot of CT, in fact the example image that I have is also going to be from cut section through abdomen. So what is addition? The instrumentation is now getting little complicated. In projection X-ray projection radiography, you had source, and you were asked to stand at the detector, your back resting against the detector or front rest, doesn't matter, and then procedure is done, you will just come out. Whereas here you notice the patient has to lie down, right? He has to lie down here. Apart from that, what is this? It is computed tomography. So I need to acquire the data from different views. So I need to have the ability to send X-rays through different directions in the body and collect them, and then put it into computer and do all the reconstruction. So both are intertwined. So you have to have both before you can see the image. How does the image look? Here is an example, right? So what do I mean, it might look, yeah, there is some image, what do I make out of it, right? So I am not a clinical practicing radiologist, so I am not well equipped or trained to say the detail of what each organ is and whether they are normal or abnormal. But what I can tell you is, mathematically what is happening is, this is your spinal cord, right? This is your back. So this is your you're lying down. So this is the back part, this is your spinal cord, and this is your front of the body, right? Front, that is your back. So clearly, if you start to imagine, if I am lying here, right? If I am lying here, and this is my front, back. So essentially this is a axial slice, that is cutting through, right? Remember axial. So now I see, okay, axial slice, so this could be ribs, right? These are ribs. So imagine, this is why I said do dummy experiments in your home, right? Just look at objects and visualize their projections. That will be very handy. So here, if you recollect, if I see through, right, if X-ray goes through, like person is lying down, you're going from front of the body to back of the body. This is tomo. So you are seeing through the slice. It is not collapsed. You are seeing through the slice. I will see, rib cage, cross section of a rib cage. Yeah, it will be like this. A cross section of my spinal cord, right? If I cut through, my spinal cord is say cylinder. So if I cut through, it's going to be whatever. So yeah, it makes sense, right? So this is the advantage of CT. You can actually start to appreciate different organs. So soft tissue contrast can be obtained, okay, and this you can do in whichever direction. Example here is axial. Good. So next to nuclear medicine, right? So in nuclear medicine, what does it mean by nuclear medicine? So here, see, until now what we progressed is X-ray is used as the modality or is the energy that is used, but notice both X-ray projection and computer tomography, we were talking about X-ray being generated outside, it is sent through the body, it interacts with the body and exits the body, and you are capturing the X-rays, the photons with X-ray energy that are exiting the body, right? And you are inferring, you are saying the amount of loss of that photon is related to the property of the tissue, right? And that is what you start to see. Whereas here, what they do is the signal, right? Here you are talking about radioactivity. So essentially they ingest, so they give you a radioactivity, it's small quantities, that's why it's called as radio tracers. What happens when you have radioactivity? We'll go into the details, but from your high school physics that there is it will break down into more stable isotopes, right? So you have radioactivity, so it will start, and in the process it will send out energy. So it will emit gamma rays. So it's again electromagnetic radiation, but with a higher energy. So they will have you take some radio tracers, right? Inject it, or oral, you can drink some solution. So it will go into the body. Then what happens? The radio tracer is going to take part, it is going to circulate in your body, and wherever it goes and wherever it takes part in some activity, the radioactive decay it will start happening. So essentially you are sending the signal source inside your body, you have a detector that is surrounding, and you catch the signal that is coming out or the radioactivity that is coming out. So if you can catch that and you say, oh, I get the radioactivity, and then you do the tomographic, right. So you do the calculation and you say, oh, I got so much activity and it came from this particular location, right. So your image is going to tell me which location is going to be how active. Okay. So in this, the slight difference is, we will say it is still non-invasive, okay, because but you notice that's a kind of sleight of hand. We said it's non-invasive, but your source is going into the body. Okay. So that is the idea of introducing a radio tracer. So you emit some photons, again electromagnetic radiation with a different energy, higher energy, and so it essentially you can local concentrations within the body you can start to tell. Okay. So nuclear medicine image reflects. So what do you see in the image? It has to do with the local concentration of the radio tracer. Some location the uptake of the radio tracer might be high or washout might be there. So that is what you are doing. So there are 3 different ways, which is again in some sense straightforward if we understand, if we can do the same thing with the X-ray, right. If you, this is just a high energy, only thing is in X-ray I send from outside, I get it from the other side, and I say in chest X-ray, projection radiography, right, I lose the depth information, right. So but I can say along which position x comma y, if z is the depth, right, you do not know where it is situated along front back, but otherwise you know. Similarly same logic, why if the source is inside the body, how does it matter? If the source is inside and it is emitting radioactivity, and the radioactivity is going to come out of the body whichever direction, right. So if I have a detector here and the radioactivity is coming out and hitting the detector and I collect, then that alone is sufficient for me to tell it came from this location. I do not know whether it came from front of the body or back of the body. So you could straight extension of logic of what was done for X-ray projection radiography, you can get what is called as conventional radionuclide imaging or scintigraphy. So you take the source, right, source is going to give the signal out, I just collect the signals and I say, oh, the signal came from this line of sight. I do not know from how far behind it came, but it came out, exited from here, it exited from here, it exited from here. So you get a distribution on the projection plane, or right, that is straight. And then if you do X-ray computed tomography, you could use the same mathematics, right, you could get tomography. So I could get single photon emission computed tomography or positron emission tomography. So we will go into the physics, so we will talk about all the details, but the idea of what is tomography and what is the view and how we get this image, now probably you start to see what is the, at least where are the aspects that are changing and that is not changing in a trivial way. Okay. So here we are talking about radio tracers being the signal source. Mathematics and the logic of forming an image and visualizing it is similar. So here again, just to show the setup, this is your patient will lie here, go in, and you have some mechanism, right, it will move around your body. You have to get views, right, you have to get views, different views, and so as to do the tomographic reconstruction. So that is what this arm will do, right, you see this L, right, this is going to move, right, it is going to move around the patient. So you can get different views. We will talk about the details, why is it placed like that, we will talk in detail later. Apart from that, apart from this, what is not seen, of course you have to have computer, all those things are fine. What is another important aspect for this, you have to prepare the patient, right, it is not like X-ray projection radiography, for example, you just walk in, you go stand there and you get the, he says, oh, job done, you may please leave. Whereas here they have to prepare you. What do you mean by prepare? They have to send the radio tracer into your body. So they have to choose some route, either make you drink and wait for some time so that the radioactivity goes to the desired part where it is going to. So, for example, if you want to see your your problems in your stomach, right, you want to see your digestive system, you want to see how it functions. So, they will ask you to drink some radio tracer that that will become active, that will depending on the activity in the stomach, right. So, metabolic activity. So, it will go, they will ask you to drink and wait for some time, and then by that time it would have probably gone to different part of the body, and only the locations where there is activity it will tag on and give the signal out. So, patient preparation is a key here. Okay. Otherwise you are going to get, of course this is not color image, but you may want to recall the brain scan of PET that I showed. Typically that is how you get. So, it will be a color coded image, the color correlating with some functional activity. So, just to relate to, again this again dates back to from the PET point of view, right, as a system dates back to 1950s. So, here we are using radiation is gamma radiation. Again in the chart that we saw, the electromagnetic spectrum, you can locate this will be high energy. Okay. And I think imaging principle we saw. So, essentially you give the radio tracer, it is going to accumulate wherever there is activity and it is going to send out radioactivity from that location, and so you infer from that activities, the concentration of this radio tracer is related to the functional aspect of that physiology. Again the advantage is whole body. So, essentially when you take the radio tracer, your circulatory system makes sure that it goes into it circulates. So, potentially you can send out the radioactivity from any part of the body, but depending on what the radio tracer is, right. If you are doing kidney, maybe it will be tagged with urea, so it may go lot more activity will take place in the kidney and the bladder. So, if it is going to be iodine, for example, it may be going to your thyroid location. So, they have, I mean we will get into the details, but the idea is you are now a walking source, right, or you are emitting your radioactive source, you are walking, and in principle it is if you can do the whole body scan, right, you might know where all the activity is happening. So, this is very powerful advantageous in especially cancer imaging, right. So, you do not know where, in which part of the body maybe there is cancerous growth, right. So, typically cancerous growth means it is going to be high, more active than the metabolically more active than the remaining. So, it has a accelerated growth, right. So, in that sense it might be deep inside the body, it is not going to be a lump that you sense, that is fine, that might be the lump, but you do not know where all it can be. So, whole body imaging of PET is very useful in getting sense of that. So, there are a lot of applications, mostly for functional imaging applications, wherever you want to see say metabolic process, myocardial heart, right, myocardial infarction or cancer detection. So, any of this it is used. I mean all of this you get a sense that from whatever we have seen so far, there is some risk, right. We talked about ionizing, we did not go into the details, but we already see, but look at how complementary the information that you are trying to get, and that is the reason that each one has its new information that it is contributing. So, it is always a case of risk versus benefit evaluation, right, and you always favor I mean ideally you want zero risk and maximum benefit. So, there are applications where you know that this is probably the way to go, even though you know the risk is there is more risk associated with it, but you may not have a choice, right. So, it is important we understand this overview, big picture view, and then the limitation of each of the modality, so that we are always in the back of the mind, right. Our engineering brain is kind of always looking for some solutions, okay. So that is what I want you to appreciate. Then we move on to non-ionizing. So now we'll just look through a couple of what is considered to be a very safe imaging modality. One is ultrasound imaging. I'm sure actually I will take back, I'm not that sure, it depends on which generation is going to the clinic. So if these are very standard ultrasound image you would have seen if you had gone right in 2000s or until a decade ago or even little earlier. But nowadays, you even get ultrasound scanners. What you probably would have seen, there is pocket scanners, there are mobile like laptop sized scanners and so on and so forth. But this is a very typical ultrasound imaging machine. Even at this size, right, when I say compared to a pocket or a mobile, this is still big. But even here you readily appreciate that this is on wheels. Unlike your CT, PET, right, this is already small, compact, you have wheels, you can take it to patient side, right, you can move around, you don't have to have a dedicated room where they have to prepare the patient and send in. So those are the advantages, and this is how a typical image from an ultrasound looks like. If you, most common image that most people would have seen is, fetal imaging. And so that kind of tells you, so every other modality has some limitation, right, with safety especially, whereas ultrasound is a staple, right, there is no known biological effect both on the mother or when the baby is developing. So it is a very vital tool for the doctors to assess the growth of baby inside the tummy. So very powerful imaging modality and very interesting imaging modality compared to the others. Interesting in the aspect that I highlighted already. All other modalities are coming from the electromagnetic spectrum, right? This is not. Okay. So here again, these are some things that are commonly available dates that I have put here, but the history of each of these modalities is itself very interesting. So I understand that a lot of work went through after World War I, the Titanic that sank. So they wanted to basically look at where these icebergs are, right, in the Atlantic Ocean, northern thing, because they wanted to prevent, or they had to have some warning system. So a lot of work was done using sound for underwater obstacle detection, right. So you would have heard sonar, right. So a lot of activities started taking place in the 1914-15s in that context. But early 50s it started really coming down as a imaging modality, and in some of the historical pieces that I read, it says it's a side effect or a positive side effect of the World War II, where there are a lot of sonar submarine detection systems, right. So there are a lot of engineers who were trained with the sonar to detect submarines, the enemy ship that is under the water, right. And then they came out, the war is done, now it's peace time. A lot of technology that was built. How do you use it, right? Brilliant minds. They had the engineering know-how, they had a target, then they realized underwater, human body is 70% water, why cannot we use the same sound in the body, right? So, you have so many smart people who are otherwise very qualified, got to do something, the war is over. So they just sat and very innovative minds put together, and they got some application for clinical as well, and therefore so that's what they say, clinical application year of, but the idea of sound and other things was a lot earlier than this. Okay. Key, no electromagnetic radiation. Okay, so that's the real key message or uniqueness of ultrasound imaging compared to the others so far what we have discussed. Look at the range, right. So now we are talking about pressure wave frequency, not the electromagnetic wave frequencies, right. This is pressure wave frequency. Pressure wave is 1 to 10 megahertz cycles per second, right? Or you get wavelengths in the order of millimeter, fraction of a millimeter. Okay. So, in some sense, as you will see when we go into the physics and the mathematics, you will realize this lambda is a key. That kind of tells you, you already see the units is in length scale. So, that means we already talked about resolution, right? We already talked about resolution, that is also in the length scale. So, we will realize that the lambda has a very important interpretation or usefulness in telling us the resolving ability of the modality. Okay. So, this is good that it is in the fractions of millimeters. What is the imaging principle? I just kind of touched upon with mountain example for echo, but here most commonly used ultrasound scanners use for imaging use what is called as pulse echo. That means you send a pulse of sound wave and the echoes start to come back as soon as it encounters obstacles, right. So, echoes from discontinuities in tissue. So, I am talking here, we will talk about details later, but just for example, when I am talking, I am in a room, right. When I am talking, it is going in one direction, but the moment there is an obstacle, there is a wall, there is some obstruction, my sound wave, right, the pressure wave gets hit and gets reflected, or it goes to other part of the room, right. Or we are interested in the part that is coming back, that is the echo. Okay. So, echoes from discontinuities in tissue. So, when you send it through the tissue, there is a lot of interfaces, obstacles. Path is not straight, it is not just water from top, that is from outside your body to inside, it is not just pure water. There are soft tissues, right, each one is slightly different from one another, and therefore, these are kind of obstruction to the path of the sound that you are releasing into the body. So, it is going to get echoes, and you are going to get echoes in several directions. Okay. So, that is but the idea is you catch hold of these echoes and say, oh, this echo came from that location. So, that location's property, how much it reflects the acoustic pressure is a property of the material. How it is distributed is what you are seeing. Okay. So, we will go into the details of that, but just for your appreciation. So, what we call as acoustic properties of the material, that is what we are going to go after. Again, this is stating as imaging volume just to be consistent with the previous modalities, but what we really mean here is the disadvantage of ultrasound is you cannot do whole body like what we saw for CT or X-ray projection. So, here you would have noticed even the slides that I showed, every time a scanner is there, there is an operator who has a scanner in what we call as transducer in hand, and they probe your body. So, essentially your field of view is very limited. You can go to a location that you want, and from skin inside the body you can go in the order of centimeters. That is a plus compared to, say, for example, optical, right. Optical comes out from the skin, you cannot really see inside. Here you can go for several centimeters. So, 20 centimeters is no joke. I mean, you can really see. So, 20 centimeters from, if I keep it from the front, I can go back and do 20 centimeters. So, I can 40 centimeters I can do, and so it's fantastic. So, it has, and that is so you can still push it further with certain compromises. So, essentially it is not volume, it's a image. There are ultrasound volume images that are coming to the markets, but still staple is your image, right. They move the transducer, you have real time feedback, and so the doctors, trained doctors, radiologists, they reconstruct the 3D in their mind, right. You do not have mathematics to reproject and do all the 3D stitching algorithms. They just, their mind stitches the 2D, they move and they visually map how the 3D is going to be from the 2D, right. So, it is a very trained speciality, it is dependent on the operator, unlike your CT or X-ray projection radiography that we have seen so far. But the good news is it is applicable both for soft tissue contrast. It is not so good in extremes. So, you do not really see it as a a staple application for a bone fracture, right. But it is very good with soft tissue contrast and blood flow using principle of Doppler. Okay, so we will get to that. So these are, so you can see blood flow and soft tissue, blood vessel and the organ that is holding the blood vessel. So it gives a wholesome picture, but it is very limited from the field of view point of view. Okay. So I have really held myself up so far, going one modality at a time, and I said, I promise that we will get to the interesting one in the end, right. Magnetic resonance imaging. So this again is a fantastic modality. What is not really captured in this image that you see is, it just shows a typical MRI scanner. What is not captured is, this requires lot of infrastructure. So this has to be in a room, and then a whole set of electronics goes around this, and there is a separate room where dedicated operator technician has to be there, and the patient also has to be prepared before they come in, right. So if they have, for example, if they have some implants or anything, they may or may not be suitable. You cannot bring your wallet in, right, keychain. So there are a lot of infrastructural requirement and technical support that is needed to do the imaging. That is not captured here, but from a technical perspective, this is one of the versatile imaging modality. So what do we mean by that? You can kind of start to appreciate why I said that from probably a very limited list that you see here, right. A quick Wikipedia will tell you that for MRI, it was, this N is nuclear magnetic resonance, right. So you have any material, you go, you have an atom, you have a nucleus, right. So nuclear magnetic resonance. How does the nucleus, right, what is the magnetic resonance property of that? That is what they were exploring. So that was part of so several different Nobel laureates at different eras. In fact, Nobel laureates, they got from chemistry they got Nobel Prize for NMR, physics they got, and then what is listed here, these are discoveries done in 70s, right. Discoveries more like, you had all the physics, chemistry of the nuclear part. Of course, after World War II, nuclear became a very difficult term to handle, right, because of nuclear bomb and all the things. So it took some time, but then they realized that property can also be used for our advantage. So the magnetic resonance property of the nucleus can be exploited, right, and that kind of opened up a lot of things, which we eventually started calling as MRI, magnetic resonance imaging. A pioneering work was done by Lauterbur and Mansfield, right. So essentially here again there was physics and chemistry from before. It is a smart, complete understanding of that, and a smart way of coming up with the instrumentation and a reconstruction strategy, right, to exploit that and come up with a image. Okay. So they got a Nobel Prize in the early 2000s for that. Of course, there was also work from Damadian, which was contemporary, who had also done a lot of work in demonstrating that you could exploit the nuclear magnetic resonance principle to come up with imaging, right, medical imaging purposes. So you can already see, very recent in the sense that you see the Nobel laureates is only a couple of decades ago, and from an instrumentation point of view, from use of MRI for humans, is actually real serious activities in the last 2-3 decades. So it's one of the newer modalities amongst the most popular imaging modalities on market, right. But you can see already how interdisciplinary it is. There is you have physics, chemistry, mathematics, and then people who put the instrumentation together. So by no means you should consider that, oh, I did a MRI was considered or treated, handled in introduction to medical imaging, so I know MRI. Please don't don't falsely convince yourself. The attempt here would be, maybe after this you will be able to appreciate the modality, you will be appreciate the different aspects that maybe you want to go brush up before you can jump in and start to push this to the next level. That is the humble hope in these modules that I will cover for MRI. But again, radio frequency, where is this radio frequency coming? Oh, there is magnetic part, and then you are going to have other set of electronics, you are going to make it spin, right, the spin property. So, it is going to there are a lot of frequencies that are involved to make the nuclear spins, and that happens to be in the radio frequency. So, it is not ionizing, that is the key. Okay. So, it is also a safe modality in that sense. So, you can see here, right, it is already low energy. So, it is nothing. So, from a safety point of view, there is not known worries about MRI. But again, this is a very simplistic principle that is listed here. Just to be consistent with the other slides, it is put in 2 lines, but it is not anywhere. The imaging principle for MRI is little complicated to explain, right. It has its own due diligence that needs to be done. Let us say for the moment, there is atom, so we all are made of material, there is atom, and so there are a lot of hydrogen atoms in our body, and so hydrogen atoms are having its own spin characteristic, and so essentially what we are interested is in understanding how, where all hydrogen is, right, hydrogen density, proton density, and how do I exploit the spin property to say how much protons are there in which location. Okay. So, this is not like straight like your tomography, because we are going to get volumes and through section what you have seen, but it is not really like in that sense tomography, not done in the same big picture like your tomography slide, but it is little more complicated than that. For now I think it is better we just say, okay, there is hydrogen atom, there is nucleus, there is a spin property, and that is what is exploited. High resolution, whole body, these are the big plus. So, you put them into the MRI scanner, you can do a whole body scan. Resolution is reasonable, right? It is high, right? Millimeters is good enough. So, again versatile I say because it does both soft tissue and functional imaging. So, you can get structural and functional imaging, structural of soft, hard, everything. So, it is powerful. Okay. So, just to summarize the introduction. So, what have we done so far? Some of the key concepts that we covered before we close this introduction and move on to the next topic. First, we talked about non-invasiveness, that is the key, right. So, all of the medical imaging modalities relies on non-invasive techniques to image the body, both structures and functions. That is a key concept. And then each of the modality is different, right. Each technique or the method is different. We call it a different imaging modality. Okay. So, each technique, so when they say CT or MRI, it's different method, right, based on different imaging modality. So, we covered some imaging modalities. This MI is for medical imaging. Some main medical imaging modalities that we have so far at least spent some time, a slide or two, few minutes: projection radiography, CT, nuclear medicine. But nuclear medicine is again a vertical that uses this radio tracers and gamma, but within that we started spelling out few specifics, right, PET, SPECT, right. So, that is under nuclear medicine. Of course, we talked about towards the end ultrasound and MRI. There are several, I mean if you recall your optical imaging, right, photography is also a medical imaging. So, whole optical imaging beyond your just photography is a rich field that is active. So, we are not covering. So there are multimodality, right? You have a combination of different modalities. So we have not really covered any of that. Okay, but fairly these are the common ones that you will encounter, and it provides a good starting point. So the signal of interest is defined by the specific imaging parameters. So this is the key. Okay, so what we will end up doing is, when we get to, we'll take each of the modality as a separate module. We'll start with the physics, right, and then go through the process, but we will take this view of signal, right. So what doctors do is, they have this image, the overall objective that we said. Doctors essentially take this image, they look for specific patterns, right. If there is something abnormal pattern, they say, oh, there is a new growth here, that might be a tumor. Is it cancer, benign? That also you can use the modality to do, or you can take it out and do the conventional way. But the idea is, the doctors look for these patterns. So they get these images, look for certain patterns, whether it is normal or abnormal for that given structure or physiology, and then they make up, based on this expected signal, they make up the health or disease of the thing. So what we need to do is, we need to take a holistic picture of each of the modality. So that means this is not a clinical viewpoint, that is why I said that. So the doctors will do that, but here our perspective is not that, it is not clinical diagnosis. For us, we need to look at it from multidisciplinary field, right, because it is going to have physics, chemistry, electrical engineering, mechanical engineering, whichever way you want to look at it. I mean, for me, it's all engineering, but you can certainly look at it if you are from certain vertical, electrical engineer or mechanical engineer. You will see that you need to still understand the other aspects to some extent before you can make a contribution to the system. So at least my view is, all this will be encountered. Okay, so you will have to have some physics, you have to understand some physics, matter, energy, radiation. We already talked about radiation, all these keywords we had in the bullet points. Mathematical reconstruction you are going to do, so there is going to be linear algebra, you are going to have statistics, right. Maybe we will go little low on biology and physiology. Little low, the reason I say little low is, of course our objective is not to do interpretations of it, but we still need to know how does the signal that we are measuring is related to the biology or physiology. So that level we should be able to at least position our understanding and the imaging concept with what is there. Key engineering, what I mean by that is implementation. Oh, you acquire this image, you register, but then somebody has to implement, either program the scanner to take multiple views, take the data, process them, form an image. All of that requires engineering implementation, either hardware or software, mostly it is interlinked. Okay, and then signal processing and image processing. Again, like I said, we will go little low on image processing. We will work on signal processing, again not from typical signal processing course that you would have been exposed in electrical engineering, for example. That is not the signal processing we are talking about. Some signal processing will be in the context of how do you reconstruct the data. So it can be seen as applied mathematics. Okay, so data handling, but at least signal processing we will cover when you get the raw data to how it transformed to an image. We will have some signal processing concept, but image processing we will avoid, okay, because that is not the course intent. All the other things, right, this we will not worry too much. Reconstruction we will, enhancement, analysis, this is not something that we will worry about. But you can see why it is interdisciplinary. All of this makes a good system. So with this background, we will cover each of the modality. We will take each modality in the same order, that we covered so far, right? We will talk about the physics first and then try to relate that if I have to use this physics, apply this physics, right, I need some instrumentation to do that. So, we will talk about the instrumentation, and then instrumentation gives access to some measurements. You need to talk about signal processing because your objective is not just the measurements, you want to see an image of that parameter, right. So, there is going to be signal processing aspect to it. So, for each modality we will go in these steps. So, in some sense that is why I said I kind of like the textbook that I underlined in the reference, right, where it is covered from a signals and systems point of view. I think this is there are several classic books that I listed in reference from the imaging physics point of view. But to a reasonable extent, the textbook that was highlighted takes a signals and systems point of view. I found the content to really gel well for a typical biomedical engineering or an engineering student who is trying to get into biomedical imaging, right. So, there is some concepts organization that involves both physics, instrumentation and signal processing. So, we will adapt this point of view. Clear? So, last but not the least, just to give a block diagram view of the same text that we had. So, this is somehow the way I have it organized in my my perception. So, I look at when we talk about imaging systems, everything is interlinked. You have to understand the physics, you have to understand the instrumentation, right, within the context of the physics, and then you have to understand signal processing. When I say understand, you might think, oh yeah, I know signal processing. I mean, I am an electrical engineer major and I did signal processing elective as well, and so I am very good at signal processing. That is good, but then when you look at the full imaging system, right, or this area of medical imaging, it still is important that not only you are very comfortable with this part, you still need to know these two. Likewise, most common job people get, right, they get image processing, but image processing of a scene photography and image processing of a medical image, you can use the same mathematics, right, same filtering you can start. I mean, that is important that you understand basic image processing, but in order to effectively apply to medical images, you need to understand the instrumentation and physics, because this gives rise to your raw data. If your image signal that is coming, the image signal that is coming is already of good quality, right, then the image processing is going to work, right. It is always better the input, your image processing will probably make it better, or it shouldn't make it worse, right, then you are not going to do additional processing. So, it is very important that we are paying attention to these three in this course. A follow-up course could be medical image processing, medical image visualization, medical image analysis. All of these could be a top-up course, specialized course, where you know the physics of the image that you are going to play with, process, right. I think that is the intent of this course. So, we will focus on these three blocks. In fact, we will cover each of the modality in this order: physics, instrumentation, signal processing, image formation. Of course, conclude with some insights on application, but majorly emphasis will be only on these three. Okay, I think with that this is good to go. Let us stop here. We will then proceed ahead with the next topic, which is again, so we are moving beyond introduction. It is still going to be some review of some of your mathematical concepts and some basics of what do we mean by image quality, and after that we are good to jump into the first topic of X-ray projection radiography. Thank you.